Good morning. Good morning. Thanks for everybody to come, both here at TAC as well as the ones who are listening in the live stream. So this is the second of this year's Interventional Radiology Grand Round. Again, welcome everybody. We'll have Dr. Gashuan introduce our speaker, Dr. Lencioni.
Thank you, Kevin. So it's a real pleasure and honor to have Riccardo here. He is an absolute legend in the field of interventional oncology. He has been involved in all the pivotal trials that have been performed on HCC. He published initially on the use of ablation for early stage HCC that led to the approval of ablation and as a recommendation, as a guideline for the treatment of HCC. He has also been involved in pivotal trials for lung cancer treatments, designing randomized trials, and as I mentioned, is truly the world leader in the field of HCC. So we are truly honored to have Riccardo here. He actually conducted practically his entire career in Italy at the University of Pisa, and then maybe a midlife crisis, maybe not. He decided to actually embark on a new career and a new journey in the US, and he actually moved about 9 months ago to the University of Miami to join a very good practice in interventional oncology there. And he's actually finding his way now through the US system and realizing that, you know, we have to pay actually a lot of taxes in this country. But anyway, with all that being said, again, Riccardo, thank you so much for coming, and we look forward to your talk on interventional oncology.
Thank you. Thank you very much, Jeff, for this so kind introduction, and thank you, Kevin, for the proposal to be here this morning to share some thoughts on interventional oncology. And because I was coming here and I was thinking to Jeff. Jeff was, I'm sure most of you know, but he was the one who organized the very first conference on interventional oncology. So even the name interventional oncology, it was him who, first decided to give a name to the use of of interventional radiology in oncology, and therefore I retrieved this document, which, as you can see, is actually published in JVIR 2005, because that was like the vision that we had for IO 11 years ago. And of course, the vision statement at that time was that research in IO will lead to significant discovery and clinical implementation of novel and effective therapeutic approaches for patients with cancer, and that in doing so, the discipline of IO would be accepted by patients, physicians, regulatory agencies as another arena similar and co-equal to radiation oncology, surgical oncology, and medical oncology. Of course, it was fully acknowledged that this mission can only be accomplished if IO is well represented by a robust portfolio of basic, translational, and clinical research. And the task force, we envision a 10-year goal of establishing a comprehensive multi-pronged approach with serious commitment to basic, translational, and clinical research. These were the goals for 2015. And of course, you can look now, as sometimes we do when we read papers, documents, letters that we have written years ago. You can take a look to this from, what was theoretically a 10-year goal, and is actually yesterday, 15. So in basic and translational research, the goal was that a number of treatments are developed and optimized through an improved understanding of tumor biology and tumor microenvironment. I think there has been major progress here. That a number of integrated imaging and interventional platform and potentially plug and play environment with multiple interventional tools and imaging guided modalities are available, this is increasingly happening, that there is a well-defined set of imaging endpoints that would serve as the equivalent of the surgical tumor-free margin, and for clinical research that there are at least 5 or 6 published clinical trials on new devices or new IO therapies not currently clinically accepted, and at least 10 published clinical trials of the devices and the options that were already available in 2005. And therefore, that there is also a clinical trial track that is integrated even in the approval processes, particularly with regard to the FDA, and used to achieve FDA indication. And the last is that IO is included in all guidelines, all relevant guidelines for the therapeutic management of patients with cancer. Now, what is interventional oncology today, and where we succeeded and where we did not succeed? Certainly, I think we broadened significantly the number of agents, energies, embolics that are currently under investigation or used clinically. We also multiplied the number of techniques, approaches, solutions, and many of the new interventions that were developed in the past decade were definitely not available in 2005. Also, the number of organs that have been targeted has been expanded significantly. In 2005, this was mostly an area for liver intervention, and clearly there has been a tremendous effort in research in IO solutions for lung, for kidney, for prostate, for bone, and even for pancreatic cancer. However, if we look at the guidelines, and if you remember the ultimate goal to be there in all relevant therapeutic guidelines, here is still where we are struggling. If you pick up some of the most common guidelines, even those that claim to be multidisciplinary efforts, so guidelines that are supposed to capture really the different perspectives for the management of cancer, it's very hard to find a note about interventional oncology. This is, for instance, a paper published by a huge multidisciplinary effort in Europe, in which for colorectal cancer, there is no mention whatsoever of any ablation or chemembolization or a Y90 procedure in any of the algorithms that are produced in this document. Of course, we have an exception, and the exception is HCC, as you know. HCC is an exception because we have ablation, we have chemembolization established as first-line therapies for early stages, non-surgical, for intermediate stages, and these have been widely acknowledged around the world. However, we usually like to show these slides. I know Jeff also like to make the point that in this area we do have level 1 evidence. For instance, for chemembolization, for ablation, we have level 1 evidence coming from randomized controlled trials, from meta-analysis. As you can see, these options actually receive the highest grade of recommendation, 1A. But it's interesting to see that those randomized controlled trials that established these procedures were all published before 2005. So they were already there at the time we produced the vision statement. Nothing happened in the 10 years during which we were completely unable to produce the level of research that would truly change the standard of care in other areas. We need to acknowledge that in this regard, we, I believe, have procedures that are largely underestimated in the context of the oncology community. Why is this? Well, one point is that, in a way, IO is continuously evolving. So it's not that, like in medical oncology, we have a new drug, and of course, how do I know that the new drug is truly better than the old drug? I need to run a randomized controlled trial, and then eventually it's yes or no. That's not our case. We continuously improve, refine, make advancement in the technology. So clinical trial timelines may just be inconsistent with this moving target. All the technologies and the devices that we are using in IO would be clearly obsolete when then you come out with like 5-year survival in the setting of, for instance, a large global randomized controlled trial. So in many instances, this is truly something that I think we need to acknowledge. For some reason, we are trapped in between, because, for instance, in surgery, this is also an area where you have continuous refinement in the way you perform surgical resection, but it's not that you have to prove every time that surgical resection is good. You just have, refinement in the way, the ability you execute the procedure. This is why I think the reason, the most important reason why we really didn't make it to have IO integrated, fully integrated into guidelines, is that we never made it to have IO, a specific approval path for IO. When discussing with regulatory agencies, they still suggest a medical oncology type model with overall survival as the only endpoint, with timelines that are clearly very long, and this approach may not be just feasible or even ethical for interventional oncology, because IO is more and more personalized medicine. And therefore, once we have something and we know that it works and we have experience and we can select patients who are likely to benefit from the procedure, this is personalized medicine, then randomizing IO versus non-IO may just be unethical. It's a little bit crazy if you think that we develop something, we refine it, and then we are supposed to do a randomized trial in which in half of the patients we deny the treatment that we have developed. This is just unethical, and really the concerns that are there about the ethics of randomized controlled trials and to which extent truly these randomized controlled trials are all based on the uncertainty principle is a big question. Because you truly can run a randomized controlled trial only if you truly don't know if the experimental arm is in fact superior to the control arm. So this scenario does not apply to interventional oncology many times, and this is why we are producing a lot of evidence in this area, which is sometimes robust phase 2 trials, prominent prospective phase 2 investigations that are very important, and that they clearly often reflect the best of what we can do. But of course, when it comes to grading this level of evidence, in the context of these oncology panels, then you hardly go beyond a weak recommendation. So how can we do better? I would use the example of external radiation. Palliative radiotherapy is in the bottom left corner, so it's actually the lowest level of evidence and the lowest grade of recommendation. So level 3 of evidence and grade 2C. I'm speaking about external radiation for HCC in this particular case. So how can I get there? one paper. This is in JCO last month, just published, February 16. It's outcomes of radiation, SBRT, versus radiofrequency ablation for HCC. So I'm bringing this paper because, JCO is clearly a top journal. I mean, not every single interventional radiology paper will land in JCO. I'm saying this because Jeff is one of the very few interventional oncologists who has, a track of records in JCO. So is this a prospective, multi-center, randomized controlled trial? No, it's not. It's a single institution retrospective study. So what they did in this paper is to compare 150 patients who had undergone RFA in the past at the institution with some 63 patients who received SBRT. And they made a comparison based on historical data, what we have always produced over the years, right? Well, you can say, well, but there is a difference between the blue line, SBRT, and the yellow line is RFA. So the difference is huge. It is huge, but that's not overall survival. It's freedom from local progression. So the primary endpoint of this study was freedom from local progression, which I can call sustained response, sustained complete response, which is what we always wanted to propose, and we were always told that's not good endpoint, because how do we know that this is a good surrogate for overall survival? That's not something that we will accept in the oncology community. You gotta have overall survival. So this paper, retrospective historical comparison, primary endpoint, freedom from local progression. And you know what? In fact, this was not a surrogate for overall survival, because the overall survival data the authors didn't feel like this deserved a figure, so it's only one line in the text, but that one line tells us that actually SBRT is below RFA in terms of 2-year survival. It's no significant difference, but let's say the significant difference in freedom from local progression is lost when it comes to overall survival. Despite the two groups being clearly unbalanced, because it's not randomized controlled trial, so many more child A in the SBRT group, 25% in the SBRT group didn't even have cirrhosis. So it's clearly a much healthier patient population. Now, how do we explain these results? Of course, when you look at comparison, I think, to me, it is always very informative to look at the control arm. So where is your reference? Now, where your reference stays. So RFA, 50% survival at 2 years. The first question is, where are the other 3 years? Because this is well established that in patients with early stage HCC, child A, mostly the kind of patient that you typically treat with ablation, the 5-year survival is 50%, not the 2-year survival. So we have 3 years in median survival that are missing here for the RFA. So clearly this bar for RFA is far from being considered like reflecting the state of the art. Actually it's the worst survival ever reported for RFA or any ablation tool. The other question is why SBRT had better local control but lower survival. The explanation is radiation-induced liver disease. This has been shown in other papers. This is a very meticulous Japanese study in which you can see that as compared to ablation, the use of CyberKnife did result in a significant increase in the child score. Patients who have compensated cirrhosis, like this patient, B7, before treatment, had massive decompensation and eventually died, like this patient, in 12 months. So my point is how this paper has been critically appraised in the oncology community. What has been the reaction? There is a commentary, an editorial, actually in Oncology Grand Rounds, that has been published in the same issue in JCO. And you can see the title, Can SBRT Effectively Treat HCC? Based on that study that we have just seen. The answer is yes, sure. SBRT is actually already there. As you can see in this paper, which is coming from probably one of the most authoritative radiation oncologist group in Canada, you can see that for tumors, you start with HCC, then liver transplant, resection, yes, no, you are here with the classic unresectable HCC. If it is very small, you can do RFA or SBRT. In the range of 2 to 5, note that SBRT is the suggested approach, or RFA, and 5 to 10 is TACE or SBRT. So based on the study that we have seen, the authors have proposed this algorithm for early stage HCC. Now the definition of early stage HCC is, I would say, a bit generous because it's up to 10 cm, up to 3 tumors. So let's say it's very generous compared to what we are used to see in other guidelines and consensus. So why am I making this point? Because really sometimes I feel like when I go to the airport that there is like the regular queue for the security, and then you have the fast track for first class travelers. Because frankly, this kind of fast track was never really the case for IO. We had to truly do a lot of efforts, and we are doing a lot of efforts to trying to produce robust evidence and robust data and level 1 evidence to support the value of what we do. And sometimes we really had a feeling that, in other areas, things are more, the process is smoother. And we still believe that this is the way to go, especially when it comes to the next steps. Because clearly, I think the area that I would like to touch base in the next 10 or 15 minutes is truly what I believe can be the most important area for future investigation. I'm speaking about the area of new drugs, new carriers, new combinations between local, regional, and new classes of systemically active agents. This is a slide that Jeff's like. I think you have produced this slide, and I think I borrowed this from some of your presentations, because this is, there are a lot of messages here that were, for instance, the basis to start working on the synergistic effect of chemoembolization and drug with anti-angiogenic properties, aiming to block the upregulation of pro-angiogenic factors such as hypoxia-inducible factor 1 alpha and VEGF that are stimulated by the hypoxia induced by the embolization. There were investigations in this area. This month we have the SPACE finally published in Journal of Hepatology, showing that the clinical benefit in terms of time to progression, in terms of time to vascular invasion of extrahepatic spread, associated with a combination of TACE and sorafenib compared to TACE and placebo is marginal. So even in overall survival, you can see that there is very little signal of the synergistic effect. So this was like, frankly, an area that really, not only based on this study, but based on a few other investigations, we were expecting more. But in reality, this has to be seen in perspective and placed in the context of the what has been like a wave of clinical trials, particularly for HCC, with these novel drugs. As you can see, many different compounds have been investigated. Most of the times, the rationale was not really tested in strong phase 2 studies. There were guidelines recommending, for instance, randomized phase 2 studies. This was never done for any of the compounds. So the bottom line is that all these trials failed, and none of them really was able to produce a clinically meaningful effect, either when combined or compared with other drugs or with other interventions. So this, I think, has produced an effect, and the effect has been a better understanding and a rethinking of the whole development strategy in HCC, particularly on the pharma side. Some of these studies, as I say, they were planned just because the drug was there, was one of the multi-kinase inhibitors. Let's say sunitinib, for instance, was shown to be better than sorafenib in renal cell carcinoma, so it was tested in HCC, not really because there was a signal that that particular cancer was potentially a good target. Things are changing now, and what we are seeing is like a second wave of clinical trials. And this second wave, I'm quoting the example of the tivantinib study as a model, because for the first time you start seeing trials that select patients based on specific biomarkers. So this is, for instance, a second-line phase 2 study of tivantinib, in which you can see that when patients were divided according to the MET positivity, there was a significant improvement in the overall survival when using tivantinib associated with placebo, suggesting that the effect was there in this particular subclass of patients. And this has prompted a large randomized phase 3 trial of tivantinib versus placebo in patients who are MET positive. Why am I bringing this example? Because there is an increasing amount of data that suggests that MET positivity may in fact be induced by taste. So this would delineate potentially a clear rationale for a combination of agents that can block and can be efficacious in patients with high c-MET, potentially preventing the upregulation of c-MET in patients undergoing TACE. So this would be a much more specific rationale for investigating a combination therapy than I think it was like 10 years ago at the time the sorafenib trials were designed. And the other area that I think is probably the one that will take the lead is the area of immune oncology. This, I'm sure you are following what's going on with ipilimumab, nivolumab in other cancers, particularly melanoma, but the reality is that these agents are increasingly tested not only in this area, but particularly in cancers such as HCC that are supposed to be potentially good targets because of the inflammation background, the cirrhotic background, and the phenomena that are associated with the cancer are thought to be potentially a good platform for an immune related agent like a checkpoint inhibitors, PD-L1, and so on. So as you can see, there is clearly a wave of clinical trials in this direction, and frankly, this is also something that I think will drive research in the next few years. Last, the ability to develop novel form of transcatheter therapy is clearly also something that will be further investigated. I mean, in a way, in most of the procedures that we do on clinical practice, for instance, with chemembolization, we use drugs such as doxorubicin or cisplatin or mitomycin C that clearly are, relatively old cytotoxic drugs. So the ability to explore a locoregional delivery of new agents that potentially can modulate a completely different effect is totally unexplored. So I really believe that interventional oncology can become the fourth pillar in cancer care. So what was the target for 15 is probably put off maybe by a few years. It will take a bit more effort, but I really think that the driver for this effort is in this area, the area where new radioactive or drug-eluting based regional hepatic treatments will be combined with new immuno or targeted systemic therapies, and even more, once we will be able to develop an immune-based regional delivery with new platform or new beads or new agents loaded into microspheres that will be able to combine a regional delivery with a systemic effect. That's, I think, the ultimate goal, and this has always been the limitation of any interventional therapy, that the effect is only local. But with these agents, potentially, you can use your ability to deliver something to the target to achieve a sustained systemic effect. If this would happen, we will have the fourth pillar of cancer care, interventional oncology. Thank you very much.